Welcome to this explainer. Today, we're taking a deep dive into the pharmacology of inflammatory bowel disease, or IBD. I actually like to think of this whole process as a clinical escalator. Basically, based on how severe a patient's disease is, we're going to climb floor by floor. We start right at the ground level with mild, localized treatments, and then we work our way all the way up to those heavy-hitting systemic therapies used for the really severe conditions. It's a brilliant example of matching the right tool to the exact right problem, and I'm super excited to guide you through it.
Okay, let's dive right in. Here's our clinical map for navigating this complex landscape. We'll start by defining the overall treatment strategy, then move up the escalator through 5-SAA drugs, glucocorticoids, immunomodulators, biologics, and finally, look at emergency bridge therapies.
Section 1. The IBD treatment landscape.
So before we look at the individual drugs themselves, we really need to understand the overarching goal here, which is matching the severity of the disease to the power of the drug. In IBD, we basically have two distinct phases of treatment. First up, induction therapy. Think of these drugs as our sprinters. They're fast-acting, meant to aggressively knock down that inflammation and induce remission over a very short period. Second, we've got maintenance therapy. These are our marathon runners. They might act a bit slower, but their job is absolutely crucial, safely keeping the disease in remission over the long haul. Keep this sprinter versus marathon runner concept in the back of your mind, because as you'll see, a drug that's great for a sprint can actually be pretty dangerous for a marathon.
Moving on to Section 2, 5-ASA, Targeted Local Relief.
All right, we are officially stepping onto the first floor of our escalator, treating mild to moderate disease. Now, if you were to just give a patient standard unformulated oral mesalamine, which is a type of 5-ASA drug, it actually gets absorbed way too early, right in the jejunum. But IBD inflammation usually happens much further down the track, in the ileum and the colon. And since 5-ASAs work primarily through direct topical effects on that inflamed tissue rather than systemic absorption, pharmacologists had to get pretty creative to deliver the drug exactly where the disease is active.
So to solve this anatomical puzzle, we use three distinct delivery vehicles. First up, prodrugs. These use a clever chemical azo bond that completely survives the stomach and small intestine. It isn't until it finally reaches the colon that local bacterial enzymes, azoreductases, actually cleave that bond and release the active drug exactly where it's needed. Pretty neat, right? Second, we have coated formulations. These use delayed or pH-sensitive coatings that only dissolve when they reach the specific environment of the small intestine or the colon. And third, for disease located at the very end of the GI tract, like proctitis, we bypass oral delivery entirely. We use topical preparations, basically suspending the drug in wax matrix suppositories or enemas for direct localized contact. The really great news about 5-ASA drugs is that they're generally very safe and highly effective for both inducing and maintaining remission. So they play both the sprinter and the marathon runner for mild disease. Most formulations of mesalamine are well tolerated, maybe just causing a mild headache or some dyspepsia. However, you should know that older prodrugs like sulfasalazine contain a sulfa moiety. And that specific component can cause allergic rashes, it can reversibly decrease sperm count and motility, and in rare cases, cause interstitial nephritis. Luckily, the newer formulations eliminate that sulfa component altogether to safely bypass those issues.
Next up, Section 3, glucocorticoids. Rapid but risky.
Okay, stepping up to the next level, for moderate to severe disease, we find systemic steroids, like prednisone and hydrocortisone. And there's a stark contrast in their clinical utility here. Steroids are the ultimate sprinters. They induce a massive reduction in the inflammatory response, often showing real clinical improvement in just 5 to 14 days. But, and this is a massive but, they are absolutely not a safe or practical option for maintaining that remission. They are strictly for induction. The reason they can't be used for the marathon is, well, pretty serious. Prolonged steroid use comes with some heavy clinical trade-offs: skin thinning, weight redistribution, often known as Cushingoid features, and even severe psychiatric and cognitive effects. On top of that, conventional glucocorticoids suppress the HPA axis, the hypothalamic pituitary adrenal axis. This is exactly why you can never ever abruptly withdraw a patient from steroids. Doing so causes a dangerous condition called adrenal insufficiency. So a strict dose-capering schedule is absolutely required to let the body's natural systems wake back up. Now, budesonide provides a really fascinating exception to this rule. While most steroids are for moderate to severe disease, budesonide is specifically used for mild to moderate distal disease. Why is that? Well, it has this unique first-pass advantage.
Once it's absorbed, it undergoes extensive metabolism in the liver before it even gets a chance to circulate to the rest of the body. This keeps the systemic drug levels incredibly low, dramatically reducing those severe side effects we just talked about. Section 4. Immunomodulators, sparing the steroids.
So what happens to patients who respond well to steroids but immediately relapse when tapered, or maybe those who don't respond to steroids at all? Well, think back to our through line of sprinters versus marathon runners. Immunomodulators like thiopurines, things like azathioprine and 6-mercaptopurine, along with methotrexate, are the ultimate marathon runners. Their clinical response is incredibly slow. We're talking weeks to months to achieve maximum therapeutic benefit. Because of that, they're not used for acute symptom relief. Instead, they act as steroid-sparing agents, allowing physicians to safely maintain disease remission over time without relying on dangerous, prolonged steroid exposure.
They do, however, carry their own risks, which we can divide into a rather elegant clinical toxicology framework with two camps. First, we have idiosyncratic reactions. These are completely unpredictable and not tied to the dose at all. For instance, about 5% of patients will unpredictably develop pancreatitis. Second, we have dose-related effects, which, as you'd guess, are directly tied to the drug concentration. The most significant of these is bone marrow suppression. Since this one is predictable, physicians absolutely mandate careful and frequent blood count monitoring, especially when a patient is just starting the therapy.
Aside from those immediate effects, there's a long-term risk to consider, which is perfectly represented by this number, 4. Patients on thiopurines have a 4-fold increased risk of developing lymphoma, specifically non-Hodgkin lymphoma. Yet, and this is wild, this really puts the danger of steroids into perspective. Because despite this very real cancer risk, physicians widely consider these immunomodulators to be much safer than leaving a patient on prolonged systemic steroids. Moving up to Section 5, Biologics, Targeted Precision Therapy.
Now we're stepping up to the highest maintenance tier for moderate to severe IBD, targeted monoclonal antibodies, commonly known as biologics. These are complex proteins designed to target very specific inflammatory pathways. First, we have the anti-TNF class, which targets a key cytokine involved in systemic inflammation. This includes infliximab, which is a partly humanized chimeric antibody given via IV. We also have adalimumab, which is fully humanized and given via subcutaneous injection. Then there's certolizumab pegol, which is super beneficial as a safer option during pregnancy because less of the drug crosses the placental barrier. Beyond the anti-TNF drugs, we have highly targeted options like vedolizumab, which is an anti-integrin given by IV, and ustekinumab, which specifically targets interleukins 12 and 23 via a subcutaneous injection.
Now, I want you to consider this question for a second. Let's say you have a patient on a highly advanced, targeted biologic therapy. Why in the world would a physician choose to simultaneously prescribe a broad immunosuppressant like methotrexate?
Well, the answer actually lies in the nature of biologics themselves. Because they are large, complex proteins, a patient's immune system can literally recognize the medication as a foreign invader and start building anti-drug antibodies to attack it. This completely neutralizes the drug and ruins its efficacy. But by adding an immunomodulator like methotrexate to the mix, you suppress that underlying immune response. This prevents the formation of those anti-drug antibodies and creates a powerful synergistic boost to the biologic's overall effectiveness. And our final section, Section 6, calcineurin inhibitors, bridge therapies.
All right, we've officially reached the top of the escalator. What happens during an acute, severe, life-threatening crisis when standard therapies just completely fail? This is where calcineurin inhibitors come in, specifically cyclosporin and tacrolimus. These are incredibly potent immunomodulators, but unlike our marathon runners from earlier, these are the ultimate last resort sprinters. They are utilized strictly for rapid short-term stabilization, basically to save a desperately ill patient from an emergent colectomy. The efficacy of IV cyclosporine in a true emergency is honestly astounding. Anywhere from 50 to 80% of severely ill patients show significant improvement in just 7 days, particularly those dealing with refractory Crohn's or severe fistulous complications. However, they are completely useless for long-term maintenance. Oral cyclosporine absorbs erratically, meaning patients frequently relapse if you try to just keep them on it. Plus, their long-term use is totally crippled by high toxicity risks. We're talking renal insufficiency, hypertension, and even seizures. So they are purely a short-term bridge to get the patient out of immediate danger until a long-term biologic or a surgery can take over. And just like that, that brings us to the end of our climb. From manipulating azo bonds to deliver localized wax suppositories directly to the colon, to combining systemic immunomodulators with lab-grown monoclonal antibodies just to trick the body into accepting the medicine, the clinical escalator of IBD pharmacotherapy is an absolute masterclass in targeted drug delivery. It really leaves us with a thrilling question. With all this incredible technology, how will these targeted therapies evolve next? Thank you so much for joining me on this explainer. I really hope you found this journey as fascinating as I do.